for glaucoma?
Thank you so much. This is a picture near my house in Portland, Oregon, and this is the Olympic Mountains, and I hope you get a chance to visit sometime. But they're covered with snow all year long. And so I'm going to talk a little bit about sustained delivery of glaucoma medicines. I'm a consultant for a company called Nycox, who doesn't have one. Ari does not have a sustained release, and this company called Envisia is no longer a company anymore. And so there's really no financial relationships related to this talk. I have research from these companies as well. So we all know the reason why we want sustained delivery for glaucoma medicines is we know that adherence is really poor. This is a paper from the United States, and I'm sure in India it's much better with adherence, but in the United States, only about 50% of patients use their glaucoma medicines over a 6-month period. So this study, what they looked at is refills. And what they found is patients were, only 50% of patients were refilling a 1-month supply at 6 months. So we know that patients have difficulty using their glaucoma drops every day. And it doesn't make any difference which glaucoma medication it is, they all have trouble. This is a paper from Stewart. This is from 1993. And it just talks about patients that don't use their glaucoma drops every day. And so those here on the left had good compliance, and the percentage of them that were stable was about 90%, but those that did not use the drop, at least 90% of the time, only 50% of them became stable, and they required either more surgery or some other advance in their therapy. There's a couple other things with eye drops, is some patients just can't get them in their eye. And about 57% of patients have difficulty getting the eye drop in their eye. They miss the eye at times. They have difficulty squeezing the bottle because of arthritis. And many times they misidentify the bottle. They're putting in the wrong bottle, like their artificial tears, in place of their glaucoma. And in the United States, there's lots of investment in what we call sustained delivery. And these are just a kind of a smattering of the different kinds of delivery ways that we have. One is by putting in the punctal plug. I'll show an example of that we participated in our institute. Vitreous injection, a company is working on that. Anterior chamber injection of medicines, subconjunctival injections of medications, and topical drops that last for many, many months, just putting on and then a contact lens-like device. So this is one of the trials that we participated in. It's an injection of an anterior segment implant, and it needs to fit below Schwabe's line. As we know, Schwabe's line is that demarcation between the angle between the trabecular meshwork and the cornea. If it gets above Schwabe's line, then it rubs against the endothelium, and you lose endothelial cells. Whether they're phakic or pseudophakic. A pseudophakic eye has a much bigger anterior chamber, so it's much easier for these anterior chamber implants to fit in there. Is there a side effect with this drop? And we also need to know what their pachymetry and their endothelial cell count to follow whether or not these are safe. So this is an example of how we would look at these implants. So this is an example here of an implant in the angle. There's Schwabe's line, and you can see this is too narrow of an anterior chamber to tolerate an implant of this size, where you can see over here the anterior chamber is much deeper, and this implant can fit nicely in the angle below Schwabe's line, because when you're above Schwabe's line, you're rubbing on the endothelium and you get endothelial cell loss. And we want the drug duration to last at least 6 months, but sometimes it would be great if it even lasted longer. So this is just a video of a procedure in a pig eye, and there's a needle that we're placing through the anterior chamber, and what you'll see is as soon as it penetrates the endothelium, we release the implant, and you can see that implant slowly floating right here. And it's really quick, really easy to do this procedure. So we participated in this study that was published in AJO, and we had 75 patients with a sustained release bimatoprost, and they compared it to bimatoprost in the other eye. So sustained release with this little implant in the anterior chamber versus drops on top of the eye. They had multiple dose strengths because they wanted to see which dose strength was most valuable. And the overall mean reduction in pressure was about 7 to 9 millimeters, while the topical was about 8.4 millimeters. So there's something interesting in this slide. What you can see here on the y-axis is you can see the mean change in pressure from baseline. And what you can see here is the different dose strengths here. And black is just topical bimatoprost. And what you can see here is topical bimatoprost had more lowering than the sustained delivery. So putting the medicine in the anterior chamber, because it's constantly releasing medicine, actually has a little bit less effect. And we're finding that with all sustained delivery. They almost do not work as well as putting a drop in once a day. You'd think that having the medicine in constantly would help, but by having this constant release of medicine, the receptors get overloaded and they get downregulated. So there's usually about a 1 or 2 millimeter decreased IOP lowering in comparison to the topical drops. About 75% of these, one injection though lasted 5 months. So that is very nice. You get one injection and your pressure is low for 5 months. There's another company that I consulted with and worked with, is called Invisia, and they had a different kind of implant that they were hoping would last a lot longer. And they had 7 sites nationally with 21 participants. And they used a different medicine. This first one I just mentioned was bimatoprost. This is travoprost. Travoprost has a little bit higher affinity for the receptors. And what you can see here in this study is when we injected this medicine, you can see a really long response time. So almost going out to almost 8 or 9 months. So this medicine really lasts a lot longer. And we have some patients that I've followed like 2 or 3 years later, and we still have a little implant in their anterior chamber. These implants have some considerations. There's movement of these implants. There's a couple papers that were published. There's an implant that you can see that was injected in the vitreous cavity, and it was for a different condition, for uveitis, and it migrated to the anterior chamber. This is one that got into the anterior chamber and it caused corneal edema. And so that is the risk of these, is if they get above Schwabe's line, they get against the endothelium, they can create uveitis and create corneal edema. Yeah, right. So this is just one of my patients, and what you can see is the implant is moving on him. Yeah. He's got a very unusual iris, but you can see that implant kind of slowly floating back down to the bottom. And so this is not what you want in an implant. You want your implant to stay right in one spot and stay in that position. He actually did very well. There was no problems with corneal edema, and eventually settled down on top of the iris. There's also punctal plug sustained release. This is another trial that we participated in, and this was a medicine made of, this was made of bimatoprost. You placed it in the inferior puncta, and it slowly released fluid into the tear film. The advantages is the easy placement. Optometrists in the United States could even use this because they can place punctal plugs. The disadvantages is you couldn't put it in with somebody with a small puncta. They would dislodge at times. You sometimes got punctal inflammation, and it was difficult to remove. And this is another device that's been used in the U.S. I don't think a whole lot about this device, but it's a ring of bimatoprost. It's a plastic or a silicone ring, almost like a contact lens material. It's slowly released bimatoprost, and you put it under the upper lid, then you tuck it into the lower lid here, and then you can't see it except for this little string over there. And what you can see here is kind of a similar thing. This is the study design. You put this in, and then you went to the treatment, and they compared it versus timolol, because in the United States, that's how we approve our medicines. And what you can see here is kind of the same story I already talked about, is the timolol, in some ways, did better than the prostaglandin analog. So a timolol drop once a day did better than bimatoprost being eluted all throughout the day. So again, about this receptors getting overloaded, sometimes it doesn't work as well. But in any case, for patients that can't use their drops every day, this is an option for them. They had this little kind of contact lens thing remained in the eye about 90% of the time. There was a little bit more adverse events, 45 versus 35%, and it was equivalent to timolol, which doesn't mean it's as good as a prostaglandin analog, but it was non-inferior. So these are the future questions with sustained delivery, because I think this is what we do need. There's no way that, most of our patients are not going to use the drops every day, but we need to know how long the device should last. One of the studies I showed you lasts 9 months or even longer. One of them was only lasting 2 to 3 months. The ideal location, whether it's reusable, and the ease of removal. And finally, how it fits in the glaucoma armamentarium. So I think sustained delivery has a potential to treat elevated IOP over a long time. We don't have a preferred location or mechanism, and the constant dosing of ocular hypotensive may have reduced effects when compared to episodic dosing, just a drop every day. Thank you.
Any questions for Dr. Steve? Any person has an experience of having used the sustained release devices? Yeah, so my question, Steve, was that the companies are pushing a lot towards us trying to put these devices, but what is your take on using these devices in ocular hypertensive? A patient who does not have glaucoma yet is actually normal, except that his pressure is high. So they've designed protocols and studies where they want us to put these devices in ocular hypertensive. What's your take on that?
Yeah, it's really difficult because these studies have to recruit patients that are very good and adherent with coming into visits, where you want to inject these medicines into people that aren't adherent. I don't know if I would do it in an ocular hypertension patient without any glaucomatous optic neuropathy, just because we know that only 10% of them develop glaucoma over 5 years, and with treatment you drop it down to 6%. So if you use some sort of calculator that proved that they had a higher risk of getting glaucoma, then I think it might be advantageous for them, but not just every ocular hypertensive patient. And I think for now, I don't know if there's a perfect device. So once we get a better device, I think that lasts for even a year, that might be a different story. So.
Yeah, absolutely.
So, I think one of the concerns is that these are still early days, but when you inject something in the anterior chamber, does the vehicle, the device that disappears over time, or it keeps accumulating in the anterior chamber? Because if you're giving 10, 20, 30 injections over a period of time.
Yeah, the question is gosh, you inject one of these and then what happens to it? And it's made of a material like Vicryl, like our Vicryl sutures. And the problem with these devices right now is the dissolving of the eluting of the medication doesn't stop at the same time as the implant goes away. So you'll have a dead implant in the anterior chamber that isn't releasing any medicine, and so you still have that implant there, and then you inject another one, and now you got 2, and then you inject another one, now you got 3, and then we have some patients that have had just a little ditzel of an implant for 2 years. So that's the problem with these implants, that they don't dissolve at the same time as the medicine quits eluting.
Over a period of time, there could be a lot of debris in the anterior chamber.
Yeah, you would have a whole bunch in the anterior chamber, yeah. And they can be visually significant for sure. So
have you seen such patients where after maybe 2 years or 3 years, there was some remnants of the device still inside the eye?
Oh yeah, this one picture I showed you of this one gentleman that was flipping up his head and then bringing it down, he was in a trial where we injected it every 6 months. And so he still has 3, we did it for 2 years. He still has 3 in his anterior chamber. It's been about 3 or 4 years. Yeah. They're very small and kind of stuck to the iris and not mobile, but you can still see them there in his eye.
Yeah. Okay.
Yeah.
Any other questions regarding the sustainable implants? Yeah, please.
When would you know that it's time to give another one? I mean, is there a particular period, or do you have to keep on monitoring wait for the IOP to rise before you put in another one?
Yeah, I mean, the reason these implants have gotten so much so much popularity to develop them as far as companies because they've asked in for retina disease and all of the anti-VEGFs for retina disease, and you injected it every month, and then it extends, from 1 month to every 3 months. So that was kind of the same idea with these glaucoma implants, is when they didn't, when the pressure was creeping up, you'd re-inject it again. But with these protocols, they have to be a standard time, and so every 3 months, we were injecting these medicines, even though the pressure might have been well controlled. And another study showed, the one study I did show, said about 70% of it lasted about 9 months. So sometimes this injection in there can last 9 months. There's also a thought that this implant, just by touching the trabecular meshwork, causes release of inflammatory factors, and that lowers your pressure too. So.
Yeah. Thanks a lot, Steve.
Thank you.
Could you